AABB top 10 blood product management papers. So we look at RBC thresholds, massive transfusion, viscoelastic-guided, harms, platelets, fibrinogen, and American Academy of Blood Products, a blood bank guidelines. We're going to see the core message. Hemoglobin is 7 for most, 1 to 1 to 1, massive transfusion, single unit, then reassess, and transfusion is not benign. First trial is the TRICC trial. Hebert, New England Journal of Medicine, 1999. This is the paper that ended the 10/30 rule. Hemoglobin 7 is safe. The restrictive group was 7 to 9. This is euvolemic, critically ill ICU adults in Canada, 838 patients. 30-day mortality was the same in the liberal group. The hospital mortality, however, was higher if you shot for a hemoglobin of 10 to 12. The RBC units transfused were 2.6 versus 5.6, so there was 54% less blood in the restrictive arm. In the less acutely ill subgroup, the restrictive strategy significantly was better. We're talking an 8.7 versus 16.1% mortality. So if your Apache score was less than 20, you're better off having a lower hemoglobin threshold. And the cardiac disease subgroup showed no harm from restrictive, but we'll see the mid-2023 trial. But pre-1999, the transfusion goal was try to get above 10. Post-TRICC, hemoglobin above 7, and that cut the transfusion rates by over 50%. And cardiac disease was no harm, but you have to watch out for active ischemia, as we'll see in the mid-trial. And of course, Apache score less than 20. You really want to avoid you want to be in the restricted group. TRICC trial was Holst et al., New England Journal of Medicine, 2014. Even in septic shock, hemoglobin of 7 is a safe threshold. 90-day mortality, looking at the same numbers, 7 and 9, showed a similar 90-day mortality, and only 1 unit was transfused in the group of the hemoglobin less than 7, whereas 4 units median transfused if you were trying to get above 9. Ischemic events, there was no difference. So you would think that in septic shock, you would be better off with a higher hemoglobin to increase oxygen delivery. But the finding in this 998-32 ICU European trial showed that the hemoglobin of 7 was just as good. It's a safe threshold, and you're going to transfuse 3 units less overall. The MIN trial is sort of an addendum to that Hebert trial in terms of the subgroup of cardiac patients. So the liberal strategy was greater than 10, restrictive strategy less than 8. 30-day death or MI was not significant, but the 30-day mortality alone was higher in the restrictive group of 9.9% versus 11.6%. This is the first randomized controlled trial showing a higher threshold may benefit ACS patients. This is a patient with acute coronary syndrome and not septic trophonitis. Okay, so 30-day death or MI narrowly missed significance, but the mortality endpoint was there. The STEMI patients showed the strongest signal for liberal strategy benefit. In that subgroup, it was 13.4% versus 17.5%. So active cardiac ischemia creates the unique physiology where the coronary oxygen delivery is already compromised. And the AABB 2023 incorporates this into the updated recommendations. So active ACS and STEMI, your target is above 10 as per the MINT trial here. And we'll take a look at the TRICC trial, which is cardiac surgery, and stable cardiac disease is 8. Okay, so that is what we know now. So the hemoglobin 7 rule does not apply in active cardiac ischemia. TRICC is restrictive transfusion in cardiac surgery, 2017, Mazer et al. So restrictive strategy, less than 7.5, intra-op ICU or less than 8, and the liberal strategy, less than 9.5 ICU, less than 8.5 in the ward. The composite outcome looks similar there, but liberal, let's look at the composite death, MI, stroke, new renal replacement therapy. Restrictive was basically non-inferior. In terms of the patients transfused, in the liberal group, 73% versus the restrictive 52%. So restricting the threshold eliminated transfused in 1 of 5 cardiac surgery patients. So basically, the cardiac surgery threshold is 7.5. So cardiac surgery is not an exception to the restrictive strategy. It's the only active ACS MI changes that calculus, okay? So TRICC showed that 7.5 is safe. The hemoglobin 7.5 cuts transfusions 28% without worsening outcomes. And remember, this is not active ACS. The next trial is the Massive Transfusion one, JAMA 2015, Holcomb. Severely injured trauma patients predicted to receive the massive transfusion. These are not patients that have already been transfused 4 units over the past hour or 10 units over a day, which is the classic massive transfusion protocol. These are patients who are predicted to need 4 units in an hour or 10 units in a day. So the 24-hour mortality, if it was 1 to 1 to 1, was 12.7%. 1 to 1 to 2 was 17%. And you could see the 30-day mortality. So it was essentially the same, but hemostasis was achieved more in the 1 to 1 to 1 group. ARDS was more in the more RBC group. So let's look at this: faster hemostasis, less 24-hour exsanguination, fewer earlier deaths from bleeding out. So if you did 1 to 1 to 1, 24-hour exsanguination, look at this, it's 9.2% versus 14.6%. The 30-day mortality difference was not statistically significant, but that 24-hour exsanguination was, so that's something to think about. But in a massive hemorrhage, you should activate the MTP early and give 1 to 1 to 1, and that way you avoid massive crystalloid dilution of the clotting factors. The next trial is the viscoelastic-guided versus conventional transfusion in trauma, ROTEM TEG-guided transfusions, faster, more targeted. No proven mortality superiority in trauma. So you have 64% versus 59.9% primary outcome, 24-hour survival, no severe TBI. There was no significance between the VHA-guided and conventional testing for the primary composite, similar mortality. So what does it do better? It gives us earlier fibrinogen supplementation, less empiric FFP use, more targeted product selection, faster turnaround versus the PT-INR. What it does improve in trauma, these are, again, trauma patients, mortality superiority. It's not available in all trauma centers. So how it changes practice, that if the clotting time is increased, you give FFP. If your max clot firmness is down, you give cryoprecipitate and fibrinogen. If the lysis indices are up, you give TXA, and it's faster than waiting for PT, PTT, and fibrinogen levels. So it enables faster, more targeted transfusion, less empiric FFP, but it has not proven mortality superiority in trauma. This is the ATACTIC trial. Number 7, you should know the difference between TACO and TRALI. This is transfusion is not benign. You should know these things cold. Transfusion-associated circulatory overload versus transfusion-related acute lung injury. So TACO is estimated in 1 to 100 to 1 in 1,000. TRALI is much less common, 1 to 5,000, 1 to 10,000 units. The mechanism of TACO is cardiogenic pulmonary edema, onset within 6 hours of transfusion. And it's the most underrated complication, slow infusion rate, diuresis between the units. TRALI, on the other hand, is also within 6 hours of transfusion, and the mechanism is anti-HLA or anti-HNA antibodies in the donor plasma, non-cardiogenic ARDS. The leading cause of transfusion mortality. The male predominant plasma donors has decreased TRALI by 50%. Leukoreduction reduces but does not eliminate. TACO, you would see elevated BNP, pro-BNP. TRALI, you would see BNP normal, no response to diuresis. And chest X-ray is indistinguishable from ARDS, both within 6 hours of transfusion. And TRALI is the most deadly, and the more male plasma donor policy has cut deaths by 50%. Next thing to know is the pragmatic plus platelet transfusion threshold in the ICU. New England Journal of Medicine, 2022. ICU patients with thrombocytopenia. So if your threshold, should it be 25 or 50, did not show any death or major bleeding in 1 month. But there were fewer transfusions in the 25,000 group. So basically, every platelet transfusion carries a TACO or TRALI risk. Remember the 1 to 100, 1 to 1,000 for TACO, 1 to 5,000 to 1 to 10,000 for TRALI. Remember that, as we discussed. Platelet thresholds are 10,000, 20,000, 50,000, 100,000, 10,000 stable, non-bleeding. 20,000 would be for an LP central line, bone marrow biopsy. 50,000 major surgery, bedside procedures, and 100,000 neurosurgery. But in general, 25,000 is safe in ICU thrombocytopenia. And you should know the context-specific thresholds. So remember the LP 20,000, and remember, let's say, a cholecystectomy 50,000. The next trial is cryostat and fibers. This is the fibrinogen and cryoprecipitate treating coagulopathy. JAMA 2023 Curry and the Cochrane database 2016. So we'll look at first the cryostat, JAMA 2023. Major trauma with coagulopathy, should you use early empiric cryoprecipitate? And it showed no significant 28-day mortality benefit, but the fibrinogen levels did increase and the clot quality improved. In the fibrinogen concentrate versus placebo meta-analysis, it decreased RBC transfusions, but no mortality benefit. So if your fibrinogen is less than 1.5, active bleeding or high risk, you would give the fibrinogen replacement. If it's less than 2, you would replace with cryoprecipitate 10 units or fibrinogen concentrate. So we use cryo here. 2 products are available. We use cryoprecipitate. So if it's less than 1.5 with active bleeding, that's grams per liter, or less than 2.0 in obstetric hemorrhage, okay? Cryostat 2 showed that the clot quality improved, mortality did not change, and the FIBRA meta-analysis showed less blood transfusion. And then you should know the American Academy of Blood Bank by Carson, Annal of Internal Medicine, 2023. Hemoglobin 7 is a strong recommendation, TRICC and TRICC. Hemoglobin 8, cardiac disease. TRICC 3, and the hemoglobin 8 to 10. Active ACS, the MINT data says we should target greater than 10 in an acute STEMI. And then the single unit then reassess was big. Give 1 unit, recheck hemoglobin symptoms before giving a second unit. Prevents reflex double unit transfusion. Leuko reduction reduces the CMV transmission. Irradiation prevents transfusion-associated graft versus host disease. So the other big statement was that you shouldn't use blood products for volume. And once again, the highlights of the AABB 2023. Hemoglobin 7 for the general ICU, hemoglobin 8 for cardiac disease and surgery, 8 to 10 for active ACS, single unit reassess, leuko reduction for the immunocompromised, and never use it for volume alone. So the other trials you should be aware of is the liberal transfusion in hip fracture patients. Liberal less than 10 versus restrictive after hip surgery. There was no difference in death or disability. So hemoglobin 8 is safe in orthopedic patients. The TRICC, which is restricted transfusion in cardiac surgery, was a predecessor to the TRICC 3. There was no difference. And then the hemo control informed restrictive and GI bleeding. This was the famous Villanueva, New England Journal of Medicine, 2013, restrictive versus liberal. It was actually better if you were in the restrictive group. And it was striking to see that in cirrhosis, the finding was still there. That's the famous that the that this was not an exception in an ICU to give more and more blood. AABB platelet transfusion guidelines, procedure-specific thresholds. We've went over this already, 10, 20, 50, and 100. So the top 10 summarized TRICC, and then TRICC, the MINT, active MI, TRICC 3, high-risk cardiac surgery. Proper was the massive transfusion. Tactic is Rotem-Teg, enabled targeted therapy, but no mortality superiority. TACO and TRALI, 2012. Pragmatic Plus, looking at platelet thresholds, New England Journal of Medicine, 2022. 25,000 is safe. Cryostat, understanding when to use fibrinogen replacement with cryoprecipitate, and then the guidelines, AABB guidelines in 2023. Thank you very much for listening.